Hey students, as I mentioned last week, I want to record this presentation so we stay on schedule, okay? So this is the same presentation that you guys are going to find on your Canvas. And also it is important to say that I did not make this presentation. It is already there, so I do not own this presentation. So what is the respiratory system? So this is an organ system that rhythmically takes air in and expels air from the body, supplying the body with oxygen and also taking out or expelling the carbon dioxide that is in our body as product of metabolism. So general functions of the respiratory system: first, ventilation, air that is coming in and air that is coming out. This is just the mechanical fact that air is going in and stuff is coming out. And that's going to be aided by the processes of inspirating, expirating, so forth, so forward. Then we're going to have external respiration. So you guys are going to see throughout the presentation that we have external respiration and internal respiration. External respiration means the exchange of gases, meaning oxygen that is coming in and carbon dioxide that is coming out on the alveoli sacs. Then we have the fundamental role that our respiratory system helps with the regulation of blood pH. Our pH is fundamental for several processes and just the balance itself of our functioning of our bodies. So if we breathe too fast or we don't breathe enough, there are going to be increases and decreases on the levels of oxygen and carbon dioxide. And everything has to work in a level, right? It has to be balanced. And that's how our respiratory system helps. The sense of smell is pretty straightforward. It has helped us through decades, thousands, hundreds of thousands of years to survive. Of course, it's something very pleasant that we associate every day in our lives. It has helped us to identify what's dangerous, what's unpleasant, but also it's something that helps us with our memory. We have very fond memories of something that we smell, and it sticks in our minds forever. This is just like a very soft function to say. And then we have filtering of air. There's a lot of stuff in the air that we breathe in, right? We have dust, we have debris coming in, so we have to make sure that whatever is coming in has to be filtered in several levels, right? So we don't want the dust, we don't want the toxins, we don't want any of the pathogens that might be in the air. So our respiratory systems helps us to filter in several levels those intruders that we don't need, either by mucus, either by being trapped, or either by being targeted by our immune system. Next is, of course, that our respiratory system is where our vocal cords are present. And that helps us, of course, to produce the vocal sounds that we do, the same thing that I'm doing right now, yammering and just telling you guys all this information, okay? Then we have warmth and moisture incoming of air. Regardless of the temperature that is outside, it is important to our bodies that the air that is coming in is warm enough. So a lot of the processes that are happening in the gas exchange happen succinctly, but also that pathogens that can affect our system are not as effective. Our bodies run on a steady temperature, and we want to make sure that that incoming of air is warmed off, so the exchange happens at a steady temperature. And that happens throughout the turbination of air in our noses, and where the air is just coming down and coming down and coming down until its final spot. So for our respiratory system, there is a division of parts. So we have, functionally speaking, a conductive portion or zone and a respiratory zone. As the name implies, the first portion, the conductive zone, it's going to be the piece where the air comes in and it's just being transported, nothing else. Not a single exchange of gases is happening in this here because they're just being transported, they're being taken, right? So at this point, there's no exchange of gas, and that's how I'm going to differentiate why the conducting zone is called the conducting zone, right? So then we are going to have the respiratory zone, and the respiratory zone is, as the name says, respiratory, because that's where the gas exchange is happening, where we are going to start to see the little sacs that I have mentioned you guys before. It's a sac that contains something. In this case, the sacs are the places that are going to be present for the gas exchange. So when those areas start to be present, respiration starts to happen, and that's what is called respiratory zone. So as I have mentioned to you guys before, the conducting zone is that glorified highway full of stations and stops along the way, so we get to the respiratory zone. So we are acquainted with a lot of these areas, and one of the important functions as well is like this conducting area where the air comes from outside to the lower portion where the respiratory portion is going to happen. It's going to be filtered because, as I said, there's a lot of debris and stuff that we don't want to be present while we are breathing, right? It warms it up, it moistens, and transports air. If the air is very dry, it's going to dry the mucosa, and we don't want that as well, because having a dry, cold mucosa, it's going to be two factors that are going to increase the likelihood of us to have any pathogens coming inside our bodies, right? So we have the nose, the nasal cavity, the pharynx, and the larynx. So we talk about the pharynx, that area that is close to our mouths. And if you guys think about this as like the nose, we got the nasopharynx, oropharynx, and laryngopharynx, right? So then below the laryngopharynx, we have the larynx, right? And that's the place where air is going to go in, go through the trachea, and then from the trachea go to the bronchi, the bronchioles, and the terminal bronchioles, all along the way. And let me erase all the scribbling here. There you go. As you guys see, air is coming in. We got bronchi, bronchioles, but nothing is happening here. Air is getting filtered, air is getting warmed, air is getting moistened, but not a single area on these sections of our respiratory system where the air is being exchanged. Just erase this, and we'll move to the following. Then we have the respiratory zone. So in the respiratory zone, this is where we start to see little sacs, where the air is going to start to happen some gas exchange. So we have the respiratory bronchioles, and then we are going to have the alveolar ducts, which is this guys here. And if you guys see, the structure starts to happen, because what happens is that like these little trees, like a tree that is getting full of little fruits, is starting to show more and more of those sacs that are called alveolar sacs. And in those alveolar sacs are going to be present alveoli. So just think about like a little grape bunch that is just filling with a lot of alveoli. And this is where the gas exchange happens. I'm just going to Just erase all this. And if you guys have seen here and here and here is where those alveolar sacs, and then in a smaller scale, the alveoli is where the gas exchange starts to happen. So the respiratory system can also be divided into a structural version. The other one was more related to a functional version, meaning what happens in the two main structures. This one is more related to the structure itself. So we have an upper respiratory tract and a lower respiratory tract. So where does the cut happen? So we are talking if the respiratory tract, the upper portion, was going to start from the nose and the sinus present there, and the cutoff is going to be at the pharynx. Starting from the pharynx below, we are going to have a lower respiratory tract. Above that is the upper respiratory tract. And you guys can see here in the slide, it's the head and the part of the neck, and then the rest of the neck down to the thorax. Something to remind, I'm pretty sure you guys have seen it, either with your kids or you guys selves, is when you go to the hospital and you're feeling pretty crummy, pretty sick, you can either have an upper respiratory infection or a lower respiratory infection. Of course, the one on this end, it's going to be way worse because it's going to affect with our gas exchange, right? Alright guys, so we have the portion of the nose. This is the part that is the only piece that is external, because if you think about it, it's the only piece that is exposed to the air. I know we have the mouth, but the mouth doesn't count for this, okay? We're going to start why? Because one of the things that the nose does, it's going to filter air, it's going to warm air, it's going to moisten the air. And if you think about it, none of that happens to the degree that happens in our nose if the air goes to our mouths, right? So it also does that by the following. When the air comes in, and think about this area here as one of our nares, there are hairs. There are also three structures called the conchi, and there's mucosa here, and the mucosa is going to have cells that is going to filter, moisten, and trap all those pieces of debris, right? So if the air is coming in, the debris is going to get caught between those pieces of hair and mucus. But also with the concha here, there's going to be some rambling, kind of like the air. Think about it like it's a fluid, because it is a fluid, just to go around and just turbinate and turbinate. And that just piling, it's going to warm up the air. Then, as I mentioned before, they are mucus-producing cells in that mucosa. And you guys are very familiar with those mucus cells called the goblet cells, but also modify speech. You guys have noticed when you have your nose all clogged up, you're going to sound different, right? And then it also has the nerves on the roof of it, where, think about like your nose here and the air coming in. There's the area where the nerves are going to be present to detect smell. And from there to your brain, so it gets processed, right? And this is also a piece of your upper respiratory tract, as well as the conducting zone. So nothing is being exchanged here. It's only taken to and filter as they go through, right? So then we have the anatomy of the nose. So we have the nose. This is, of course, a transversal view of the nose. So you guys are familiar with the lower portion. We were talking about the digestive system here. So here we have the vestibule, which is the frontal or anterior portion of our noses. This is where the air is going to come in. This is where our nares are in. And then we have three little guys that should resemble like a shell. They're called the conchae. So we have a superior turbinate, a middle one, and then an inferior one. And then underneath those guys, we're going to have some openings called the superior meatus, middle meatus, and inferior meatus. And what's going to happen here is like all these areas are rich in vessels, and the air is going to come through here and just get moistened and warmed up, right? And get filtered as well. And then all this structures are attached to a piece that is going to divide each nair, and this is called a septum, right? And that's where we have two nairs that are going to be divided by a septum. So as we were talking before, we're going to have a vestibule, which is kind of like the lobby entrance of the nose. And then the conchae, as I mentioned before, we have a superior, middle, and inferior nasal conchae, okay? And these are structures that are going to look apparently like a shell. We have a superior, a middle, and an inferior one. And underneath each of those structures, we're going to have a meatus, which is the space between all of them. Then, as I mentioned before, is where the air is going to come in, get filtered, get warmed up, and all the way down to the next portion. So on the microscopic level of our nose, we're going to have more tissue. So you guys are very familiar with this piece. This is the mucosa, right? And here we're going to have a different kind of epithelium we have not talked about. We have talked about columnar epithelium, but these guys are ciliated, which means they have a little tufts, like notches of hair, like a troll doll. But also, instead of being simple or stratified, it's something in between. It's pseudo-stratified, meaning that it's only one layer, but it has the appearance of being stratified. The thing is, like, looks like a bunch of sausages, and it looks like there are different layers, but there's only one. Okay. And one of the functions of this area, as I mentioned before, is it filters, but also the cilia works as little traps where debris and toxins and little microbes are going to get caught. And also they're being caught by these little cells, which we are familiar, which are called the goblet cells that produce mucus, right? So in this cross-sectional portion, you guys are going to see more stuff that we're already familiar with. So we have our conchae, here, here, here. So we get superior, middle, and inferior, and the spaces that are going in between, right? The meatus, right? But also, we are going to see that we have structures, at least one, that we saw with the digestive system. So we have a tonsillar, or I should say a palatine tonsil. We also have a nubular tonsil, and we have a lingual tonsil. And as we were mentioning before, if these guys are here to watch for intruders, these guys do the same, and it's the same function here. So it's just more related to the fence of the body, right? Then here we are going to start to see structures that are pretty important. They're called sinus, and they are known as like the resonant boxes of our bodies. So they are going to be related to some bones in our bodies. So we're going to have an ethmoidal sinus, and this is because of the ethmoid bone. You're going to have a frontal sinus, which is related to our frontal bone, and there we're going to have an sphenoidal sinus, which is related to the sphenoid bone, but also we're going to have a maxillary sinus, that which of course we're not going to see here because the cut is not done to that, but it's going to be in our maxillary bone. Okay, so we have 1, 2, 3, and 4. And this, so as mentioned, this sinus or sinuses are there to have several functions. So we have 4. We have a maxillary sinus, a frontal sinus, an ethmoid sinus, and you guys don't see it here, but in this cross section is better, is the sphenoid sinus. All of them are cavities that have mucosa as well, and they produce mucus. But there are also hollow areas in our skulls, not here of course, but here. They are going to make our heads lighter. But also there are resonant areas where a voice is going to be sounding different. If this guy's getting inflamed because of an infection, of allergies, or they get plugged and mucus accumulates there, we are very familiar with that, and that's called sinusitis, right? So we just will add situs, right? Which is inflammation of the sinuses. So the pharynx is an area that we are very familiar with because we saw it at the digestive system, also known as throat, part of our upper respiratory tract, and also part of the conductive zone because no gas exchange there is happening, right? So divided in 3 pieces, or mainly 3 pieces. So we have our nasopharynx because it goes located at the area of the nose, right? And then we got the oropharynx, which is related to the area adjacent to the mouth. And then we got the laryngopharynx, which is located or adjacent to what? The larynx, right? So nasopharynx, postnasal cavity, and soft palate. You see it here. Nasal cavity, soft palate. Then oropharynx, it's the oral cavity, soft palate, downward to the epiglottis. Before everything gets too busy here, I'm going to erase this. Then to the laryngopharynx. So it mentions the hyoid bone, and this is a bone that barely I passed by when I was talking to you guys about the GI system. It's a bone, just think about like antlers. It looks like antlers, and it's this little bone here. Okay, so it is adjacent to this area here, if you guys think about it. So we have the hyoid bone here, we got the posterior area, and then the air, instead of going mainly to the esophagus, because otherwise we're going to get distended, is going to go here to the trachea and then to the other portion of the conducting zone. So going into more detail with the pharynx, we got the nasopharynx, right? So it's the portion of the cavity, or also known as the throat, that is going to be behind the nasal canal. So we have the soft palate here, the uvula, and the pharynx. So there are several structures here that are going to be important for your knowledge here. So we're going to have a pair of pharyngeal tonsils, and here they are. And of course they are related to immune system functions as the ones down here and the ones down here, right? Because we have, this is the opening area for a lot of intruders to come. Also, they're known as the adenoids, and when these guys get inflamed for different reasons, you will see it very often with Down syndrome kids, sorry, or they just constantly inflame, they are going to obstruct the breathing and you're not going to sleep well, or you're going to struggle with breathing. So those are taken out because they are one of the factors contributing to obstructive sleep apnea. All right. Then we also have the opening of the auditory tubes. There are those itty bitty 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 openings there, and those are being connected to the middle ear canal, right? So just think about, like, this is your nasopharynx, this is the space, and this is the opening in the canal. So if you guys think about it, when we have an inflammation or an irritation or an infection in that area is going to get affected, and that's why our ears sometimes get infected or even inflamed. Okay, there's also some problems with pressure there, and that's why also sometimes it affects our hearing. So now we are going to talk about the oropharynx. So this is the piece of our throat, if we're going to simple terms. So it's going to be behind our oral cavity, right? You have the soft palate here, and we have the epiglottis here, right? So as mentioned before with the other piece of the pharynx, all these areas are going to be lined by mucosa, and you guys are very familiar with that right now. So stratified squamous epithelium, because there's a lot of stuff that's going to come in and it's going to cause some lesion, and we want that area to be constantly replacing and regenerating itself, right? So we have two pairs on each side of tonsils, which, as we said before, they're related to the immune function, and they are the palatine tonsils here, and then we have the lingual tonsils here. And this, guys, if you think about the ones on the oropharynx, the ones in the palate, and the ones underneath the tongue, it's called the Waldeyer circle. And this is, if you think about, like a main checkpoint for intruders to come in. And if they get inflamed, all these guys can be taken out if it becomes enough of a problem, or if they're too large. Because what are they doing? They're obstructing our breathing, right? And that's when it's also a severe problem, because it's not going to let us sleep or breathe properly when we lay down. So they need to be taken out. So then we are going to have our laryngopharynx, because it's that portion that is adjacent to our larynx. So it's going to be the opening of the larynx and the epiglottis, and of course it's again layered, or lined I should say, by squamous stratified epithelium, because there's a lot of stuff that is going to come on the way and it's going to affect this lining, so it needs to regenerate too, right? Very straightforward. And this still is part of our upper respiratory tract, and it's also a conducting area of our respiratory system, because no air exchange is happening there. So we have our larynx, and this is also known as our voice box. This is one of the entry points where the air goes to our lungs. Of course, there are a ton of structures before it gets to the lungs, okay? So it's of course part of our upper respiratory tract and the conducting zone, and this is why, because no air exchange happens there, right? So we are done with the pharynx, okay? Now the larynx is our friend in question, okay? And it's gonna be here, all this area, okay? So there are several structures that are important, and there are landmarks or structures that you guys need to know. So we have the thyroid cartilage, and that's the one boys and girls and everything in between are going to have, and that's also known as the Adam's apple. And a little bit below that cartilage is where the thyroid is going to be. Epiglottis, we are familiar with this, friend, because this is a piece of structure that's going to help us to prevent a food when it comes in to go to the wrong spot, right? Then I wanted to erase this. There you go. is the cricoid cartilage, and it's this little friend over here. Okay, it's a ring shape, and it's also below, right underneath, I should say, of the thyroid gland. Between the cricoid cartilage and the thyroid cartilage, it's a landmark that is pretty important when they need to do emergency intubations or where a tracheostomy is going to go. Then we have the vocal cords. They're just like structures, this shape, with different ligaments that are going to help us to produce the voice, okay? Then the arytenoid cartilage, we are not going to see them here because the cut of this slide is not for that, but for now think about them as a pyramid shaped structure, okay? We're going to see them more about that in the next slides. So now we have some more of the structures that we were talking about. So right here in pink, we have the thyroid cartilage. Some people think about as a shell or as a butterfly. To me, it looks more like a shell. And then it protects the vocal cords. It also has the laryngeal prominence that is more evident in males, just testosterone related. And then behind it is the epiglottis. And this little bone structure here that you guys see covering and not letting us see the glottis is the hyoid bone. If you guys use your imagination a little bit, it kind of looks like a pair of antlers if you guys think about it. Okay, and below, so we have this friend that people say that looks like a butterfly and is full of nodules. It's a gland. This gland, it's called thyroid. For our purposes today, we are not going to talk about the thyroid. Of course, you guys are pretty familiar with it. But underneath that, there's the next cartilage called the cricoid cartilage. Okay? It's a ring-shaped piece of cartilage that is made of hyaline cartilage. And if you guys go back to the presentation that I did about tissues and histology, you're going to find the hyaline cartilage. Hyaline cartilage is a very flexible piece of cartilage, and it's called hyaline because it resembles glass, or so they say. But it's very easy to spot when you guys see your histology pieces. You're going to see it has like little spots, and it's very, 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 very flexible, okay? And that's a very important piece of histology here you guys are going to see on your thyroid cartilage, your cricoid cartilage, your rings of the trachea, because they're very flexible and yet sturdy, okay? So things that we haven't talked about, I think we cover everything on this slide, okay? Behind the thyroid cartilage, our vocal cords live, okay? Going forward to more structures, so we are already familiar with the thyroid cartilage and the Adam's apple or the laryngeal prominence. We got the cricoid cartilage here, no longer covered by the thyroid, and then this little notch is the cricoid ligament. Then this view is going to help us to see a few things, the one below. So we have our epiglottis. Then we have our vocal box here. And then we're going to see the ligaments that are going to make our sounds be a thing. So we have the vestibular fold where the fake vocal cords are, and then the true vocal cords underneath. And those are the ones that produce the sound, okay? Then, if you guys think about it, this is posterior, this is anterior okay? So this is what we're seeing. This here is what we're seeing here, okay? And this here is posterior, seeing it from the back, okay? So we have the epiglottis, the glottis, which is that opening. And then here, even though the color doesn't favor them, and I'm gonna erase it a little bit here, and just want to point them here, here, and here, are our arytenoid cartilage, and we're gonna talk about them later, okay? So also here we're gonna have our tracheal cartilages, which are rings, go this way, and helps us with our trachea to be stable, yet this cartilage is very flexible, so it helps us not to collapse the trachea, to keep it sturdy and open. For some people that are born with some congenital defects, they have a floppy trachea, so they are very prone to that area to get collapsed, right? And we don't want that because we want air to go in, right? All right, larynx. We're still speaking about the larynx. So this is a posterior view, okay? So the glottis is the area where the vocal cords are and the air goes through. So we have our vocal cord ligaments here, which is going to open and close, open and close. And also we have our arytenoid cartilage there too, okay? So this, guys, and I'm going to erase this here, better, okay, perfect, is where our vocal cords are going to attach. So these guys here are the arytenoid cartilage, and if you guys use your imagination, they are kind of shaped like a pyramid. So what they're going to do is help us attach the vocal cords to the cartilage, okay? The tension of those vocal cords are going to have the pitch effect on your voice, okay? Then this is an anterior and posterior view of our larynx. Same structures, epiglottis. So this one is anterior, this one is posterior, so you guys are like oriented. We see the cartilage here, the cricoid cartilage here, and then this butterfly, or so they say, shape structure is the thyroid. Seeing it from the back or posteriorly, we have the epiglottis that is going to help us to protect the glottis and the air coming down, right? And then the cricoid cartilage, these little guys here, are adjacent or aside, or in the back, I should say, structurally speaking, of the thyroid. So they're called parathyroid glands, and they help us with the calcium absorption and maintenance of calcium in our bloodstream. Pretty important gland, and group of glands, and they're very significant. And we're going to talk about them later when we get to endocrine system, okay? This guy here that looks like antlers is, of course, our hyoid bone. Itty bitty bone, but very important too because it helps us with this structure, okay? All right, so we are going to talk about the vocal cords. So we have the vocal cords here, which are two pair of horizontal, beg your pardon, ligaments or folds. These are the ones. Okay. And then we have the true vocal cords, so the ones that produce the sound, and the ones that are just vestibular ligaments, have no function in sound production. Okay. So the ones that are going to do that are the vocal ligaments, and they're going to be the lower folds. Let me stress that, the lower folds. the lower folds, okay? The false vocal cords are going to be the upper folds. Again, upper folds. Upper, no sound. Lower, yes sound. Okay, so this is the physiology of the vocal cords. So they are closed while we are speaking, so the vibration's happening. So that vibration and that pulling tug is what is going to produce the sound, okay? And then here we're going to have something called the Valsalva maneuver. You guys are very aware or acquainted with the Valsalva maneuver, and if not, that's fine. When we bear down, so turn like when you strain, that's the other way you can think about it. When you strain, you're producing pressure on your body, okay? Strain or bearing down. And this expels air. But if something is closed, it produces that pressure, okay? So this has different functions. It helps us with expelling air or feces out of our bodies. It also helps to stabilize the trunk during heavy lifting, but sometimes the older we get, this thing also makes our heart rate go down. And what happens sometimes when this goes severely fast and low enough, we can pass out. And that's a vagal response. Heart rate goes down. Alright, so now we have our trachea, aka windpipe. So this is something you guys are very familiar with, to the point I think if I tell you guys to point your trachea, you can, okay? So, just a little bit of table setting here. This is just like a line, the little imagination to divide. So we got the front here and we got the back here. Anterior, posterior, right? Front, back, anterior, posterior. So we got our esophagus here, we got our trachea here, okay? So it's still part of our conducting zone because there's no gas exchange happening here, but now this is the lower respiratory tract. So this is the structure that goes right before the lungs. So we have the trachea here, and we talk about this. So this is larynx, this is trachea, okay? Before that we got the lung. After that we have the lungs. Trachea, very flexible, 4 to 5 inches long and 3/4 of an inch in diameter, okay? So sits anterior, as we say here with my very, very perfect diagram, and it sits in front or anterior to the esophagus, right? And it has approximately 20 C-shaped hyaline cartilage rings. So the C goes like this. So if I'm seeing it from above, this is anterior, this is posterior, and this is where the notch or the space that is not covered by the cartilage is, okay? So what it does, I should say, it's give the trachea the flexibility it needs, because we are moving our necks, we're doing a lot of stuff that can predispose that trachea to collapse. And this is kind of like the support system for that trachea to be prevented from collapsing, okay? And this is where the trachea cartilage are. And you'll see them here, here, here. As we say, there are around 20 of them, C-shaped. Here in this cut, this is a cut of different structures here. So, anterior, front, posterior, back. So there's a friend that we have spoken several times before about. As you guys see, that guy here is the esophagus. There's muscle, and we have a lumen, we have a mucosa, we have muscularis, and we have a serosa, right? And since it's posterior, it means that it's in the back or posterior to our friend the trachea, which is bigger, at least because it doesn't need to be collapsed like esophagus sometimes can be. So we have the hyaline cartilage rings, and as you guys can see here, it's C-shaped right here, and as you guys can see it here. So it needs to be sturdy but yet flexible at the same time. Okay, so here we get to see a little friend that we have spoken about. There's two little structures that go across, because it has two lobes and an isthmus in between. It's called what? The thyroid gland. Okay, and we are not going to talk about the thyroid gland because it's not the purpose of our text. But also we have here some trachealis muscle, because yeah, has to be moved, and there's some flexibility here and some movement that happens. And of course, seeing it from above, this is a lumen, and this is where air is going to go down, right? And it's going to be affected by the mucosa and the ciliaris epithelium, pseudostratified, that is going to be in contact with. Structures and organs in the respiratory system, continuing with what? Trachea, right? So as I was telling before, we have the first layer, which is called the mucosa, and we have the epithelium here. And as I was mentioning before, there is pseudostratified columnar epithelium here. And the reason that we don't see the squamous stratified epithelium is because that is not the function of this area. In this area, the only thing that should be going through is air, right? So yet we have to make sure that this air is being filtered, because they're still being filtered in warmth and moisture. So we have goblet cells here, and we have this pseudo stratified, because it's not a truly stratified layer. It's a bunch of imposters that are trying to pretend to be different layers, and it's just one set of columnar cells, epithelium, but they have a notch of hair that is called cilia, and if this hair and the structures is present in all these cells, it's called ciliated epithelium. Okay, so what is the function of it? Catch unnecessary and undesired intruders such as dust. But also they have a function of being moving. They're in constant movement. They're like think about like the grass and meadow. They go back and forward, and the reason about that is to move and trap those particles. Okay, and they take it back to the pharynx when they're swallowed to the stomach, because what's in the stomach? Acid, which is fantastic to kill pathogens. Okay, so the trachea ends up dividing in two. This point is called the carina, which is basically a Latin term that means pear. This is where the trachea ends and divides into two main bronchi. Okay, still part of a conductive zone, because there's no gas exchange happening here. So again, goblet cells, pseudostratified ciliated columnar epithelium, and this guy here is a lamina propria or a submucosa. All right, going forward to the histology of the trachea. We now can tell now that there are two different structures here, as you guys can see, and if you guys can refer back to the histology slide presentation that I did, now you guys can tell a little bit more apart like what is what. So we have an esophagus here, but also we can tell that there's a thick muscle layer here that is not present in this because the function is not the same. Food goes here and needs to be moved through a strong layer of muscle, right? Here's not the case. Here should be only air going through. So we have trachea, but also needs to be flexible because we're moving our necks all the time, and it needs to be flexible but not able to collapse, and that's why these cartilages here are present. Okay, this is the tracheal cartilage that is C-shaped, but also sometimes the trachea needs to do some contracting of its own, so it has a little layer of muscle. Okay, to your left you'll see the first layer of the trachea called mucosa, right? So we have the ciliated pseudostratified epithelium. We have a submucosa that is full with mucosa glands, but also other goblet glands, and this is because we need to produce mucus and needs to be moisture. Underneath is the submucosa filled with some connective tissue, but also some other cells, right? Right below, and this is, you guys are going to see, and I show you guys on my histology slides, this is how hyaline cartilage looks like. It has a very distinctive look, okay? It looks like a sea of chondrocytes, which are the name of these cells here, but you will see it. It looks like that, and if you guys go back to that histology slides, you guys will be able to identify them. That's connective tissue, and this is what prevents our trachea from collapsing. Then after the carina, which is this division here, and carina means pair, and that's why that's called, it's Latin for pair, as in two. We have two main structures, still part of a conductive zone and now part of our lower respiratory tract. We have a right main bronchi and a left main bronchi, also called primary. So there's one for each lung. It also contains the C-shaped hyaline cartilage rings because we don't want them to collapse. The right one is wider, shorter, and more vertically oriented compared to the left one. Let me say that again. Wink, wink, nod, nod. The right main bronchus is wider, shorter, and vertically oriented. Okay? And this is because this guy here, the right lung, has an extra lobe, and it's bigger, put an asterisk on that, than the left lung, because this guy here has only two lobes, but also has to share space with our heart. Okay? Perfect. So now we have the bronchi, still part of our conducting zone, still part of our lower respiratory tract, and all the structures starting from the below the larynx are lower respiratory tract, right? So as I was saying before, the right lobe, so we're seeing it here, the right lung, the right bronchi, it has 3. The left has 2. Secondary bronchi go to each lobe of the lung, respectively speaking. As I was saying, the right lung has 3 lobes. The left lung has 2. Okay? So this is the branching of the branching of the branching of the branching. Think about that. The branching of the branching of the branching. Just think about like a tree. Trunk becomes branches, and branches become stems, and so forth, right? So The tertiary bronchi, still part of the conductive zone because there is no gas exchange. It's found within the lung tissue, and it supplies one segment within the lung. Okay, approximately 10 of each in each lung. Okay. All right. So now we have a little visual of how everything comes together. We have the things that we have talked about. So we have an upper respiratory area. It stops at the larynx, and then we have a lower respiratory area or tract starting by the trachea, right? So we have our trachea that is going to divide at 2 at the carina, right? And then we're going to start with the primary bronchi. So we have 2 primary bronchi. We have our right one and a left one. We talked that the right bronchi or bronchus, it's wider, shorter, and more vertical because it has an extra lobe. The right lung has an extra lobe, right? Then we have secondary bronchi. We have 3 on this side, and we have 2 on this side, right? This branched out to tertiary bronchi. You see here, they just branch out. Bronchi here, okay? And here, bronchi, right? And we are getting close, getting super close to what it is only conducting and what it becomes. All right, the bronchioles. So this is after the tertiary bronchi, like the end point where the branching of the branching happens. So things divide into even smaller stuff. And these patchways are called bronchioles. Still part of the conductive area because gas exchange doesn't happen here. And again, everything, since we spoke from the trachea on, it's still lower respiratory tract, right? There's still more branching of the branching, so they're called terminal bronchioles. Okay? And again, this terminal bronchioles are the last structures of the conducting zone. So we made it to the end of the conductive zone. Terminal bronchioles, the last structures that are part of the conductive zone. Here, so we have spoken of the lower respiratory tract, all of them still conducting zone. Trachea, then divides in 2 after the carina into primary bronchi, a left one and a right one. Then those bronchi branch out as well to secondary bronchi. There is 3 on the right side, 2 on the left side, and then they branch out into tertiary bronchi, right? And this is branching of the branching of the branching of the branching of the branching. Thinking about the tree. And those bronchi will divide into bronchioles, and then those will end up being terminal bronchioles. The end of the conductive zone happens here, okay? Where does the conducting zone happens? The end of this, structurally speaking and physiologically speaking, happens here, okay? All right, so structures and organs in the respiratory system that are pathway and passage of air in the conductive zone. Nasal cavity, pharynx, larynx, trachea. The branching out starts to happen. The bronchi, primary bronchi, lobar bronchi, or also called secondary bronchi, and then tertiary bronchi or segmental bronchi. Then we got the bronchioles, and these guys are going to branch out to terminal bronchioles, right? Okay, the end of the conductive zone. All right, now we're going to talk about the lungs. The lungs, we have two, only two, are spongy cone-shaped organs in the thoracic cavity, okay? As we were talking in the digestive system, like many organs you will see, they will be covered in a layer. And this layer will be one that is visceral pleura, that is going to be covered in these guys. And then that area of that membrane is going to go to the thoracic area and cover the walls of that area. Alright? That's going to be called parietal pleura. A layer that is cover the lungs, visceral. A layer that is cover the walls of the thorax. It's called pleura. And of course, there's a space. Tiny as it is, but there's a space. But there's going to be a little bit of friction, and there's going to be a little bit of liquid happening there. That is called pleural space. I repeat that. That space between these two little layers is called pleural space. And there's a little bit of viscous fluid that is going to help us to prevent friction, okay? Each lung has its own chamber because they are selfish. And then, of course, anatomically speaking, the right lung and the left lung are different. We have spoken a little bit about why. The heart is involved in that, and that's why one is bigger than the other. Alright, so we have the lungs still here. So, right lung, left lung. This space here is where our friend, the heart, lives. Okay? So, if you think about it, their lungs, some way, with a lot of imagination, they kind of resemble like a pyramid, right? So, in the top of the pyramid, there's an apex. That's why also people say they are the apex, or there's an apex predator, is because they are the top, right? Then we have a costal surface, which are the portions that touch the ribs, right? And then we have a basal surface, which is in touch with the diaphragm. And our friend, the stomach, is underneath that, and all our nice digestive portions of our system also live here. The liver is also here, underneath the diaphragm, okay? Then the space where the heart is occupying its space is called the mediastinum or mediastinum. That's what it's called, mediastinal surface. We're talking about that area. Due to its orientation, the heart tends to occupy, more often than not, the left space, and that's why the left lung has this shape, also why its size is affected, and that's why only it has 1 and 2 lobes, instead of the right one that has a 1, 2, and 3 lobes. Alright, so speaking of lobes, so the left lung is slightly smaller. It's not like it's super small, but it has 2 lobes, a superior lobe and inferior lobe. And between those lobes there is an oblique fissure. And it's oblique because it goes obliquous, okay? And there's a cardiac notch. This is where our very generous left lung provide a place for the heart to live. Okay? Then we have the right lung, the largest of them too, and it has 3 lobes: a superior lobe, a middle lobe, and an inferior lobe. So it has, of course, an oblique fissure, but also has a right or horizontal fissure. Okay? So these are lateral, meaning being seen from the outside, and then we have medial, seen from the inside or the more innermost lungs. Okay, so we have our right lung, both sides, and we have a left lung. One of the things that you can spot right away when we see the lungs is if it has 3 lobes, we're talking that it has to be the right lung, right? Has 2 lobes, has to be the left lung. And as you guys can see, they are oblique fissures. Okay? But also the right lung has a horizontal fissure. Superior, middle, and inferior lobe, superior and inferior lobe. Okay? There is a structure that is very important, and this is the piece where the bronchi are going to go in to the lung, and it's called the hilus or hilus. And it's pretty important because this is the attachment part where the bronchi, the conducting structure of the primary bronchi, is going to connect to. Okay? Then we have the base, which is the bottom, of course. The apex, which is going to be the top. If it's touching the ribs, it's a costal surface. If it's touching the mediastinum, it's a mediastinal surface. Right, looking from the medial aspect, meaning if you think about like the core. So if we are like stepping like next to the heart, you'll see our hilum. And the hilum has the primary bronchus, pulmonary arteries, pulmonary veins, bronchopulmonary lymph nodes, and nerves. And if you think about this bunch here, it's something that you guys are going to see in a lot of places because we need, of course, deoxygenated and oxygenated blood to nourish any alive structure in our bodies. But also we're going to have this third kind of vessel that we don't think about enough, which are lymph, or the lymphatic system, which also comprises of lymphatic vessels and lymphatic nodes. And these are the guys who also provide a lot of the immune cells. And to a lot of extent, because everything needs to be moved and coordinated and regulated from a movement and autonomic standpoint, they have to have nerves. Okay? And of course, structurally speaking, this is where our primary bronchi are going to be in, right and left. You see it here, everything is nice and beautifully color-coded. I'm going to erase that so you guys can see what I'm talking about, okay? Okay? In the gray, bronchus, or the primary bronchus. If I'm seeing it from here, since there are 3 lobes, so I'm pretty sure that this is our right lung, right? So we have pulmonary arteries in the blue, pulmonary vein, bronchopulmonary lymph nodes, and I will include maybe some vessels, and nerves. All right, respiratory bronchioles. So we are done with the conductive part of our respiratory system because they ended up with the terminal bronchioles, right? So now we're going to talk about respiratory proper bronchioles, okay? As I mentioned here, They're the first structure of the respiratory zone, right? This is when the gas exchange start to happen. So we have our terminal bronchioles here. Oh, I don't like that color. There you go. So we have the terminal bronchioles here. And now we start to see sacs. Those are alveoli. Okay? So this is when the gas exchange start to happen at a very microscopic level. And now we don't have epithelium that is going to start to trap staph with cilia, where we're going to have simple squamous epithelium. So instead of stratify, they're simple. And we're going to go more into detail later why this is the case. Alright, so we have the alveolar sacs in the alveoli. So to each respiratory bronchiole will be from 2 to 10 alveolar ducts. The alveolar ducts contain small amounts of alveoli, but they are not going to be the main areas. They're going to be full of alveoli. So we are going to see that the bunch of the grapes are called alveolar sacs, which is a cluster. That's what I said, the grape bunch. And a group of those guys is known as alveoli, as the plural. Okay? The reason that these sacs have simple squamous epithelium is because it's super thin, super thin, where the gas exchange starts to happen. They are part of the lower respiratory tract, and as I mentioned before, that was long before established, but they're also respiratory zone. Okay? Okay. So going from the bigger picture, we are done with the terminal bronchioles, and we are transitioned to the respiratory bronchiole proper, right? So here we see it again. Terminal bronchiole and respiratory bronchiole, and we start to notice because these guys are starting to show up, right? The respiratory bronchioles branched out into alveolar ducts, into a bunch of alveolar sacs. Those alveolar sacs are called in plural alveoli. Okay? And this is where the gas exchange happens. So now we're going more and more microscopic. So now we are at the level of the alveoli. So they are grape-like sacs. They're covered by pulmonary capillaries. And this is very important because those pulmonary capillaries are carrying something, right? They're carrying blood. That blood is going to come from everywhere, deoxygenated. Something is going to happen at the level of those alveoli that is going to create a gas exchange and have that blood going away from these guys rich in oxygen, or at least richer in oxygen than when they came in, right? So we have type 1 cells in those sacs. We have type 2 cells in those sacs. And we also have alveolar microphages. As mentioned before, phage, this little term here, is Latin for eating. Macro, it's basically big. When we're talking about cells, we're talking a cell that is big enough, but also eats something, debris, intruders, immunology, right? This is an immune cell. We'll talk more into detail about these two guys here. So we have an alveolus showing its cellular components. Group of alveolus is called alveoli, okay? So this friend here, by itself, it's going to have a lot of main components. We have spoken about a type 1 alveolar cell, and this is the one that is going to have the lining of our alveolus. This is in conjunction with the capillaries where the gas exchange is going to occur. Okay? Gas exchange is happening here. Gas exchange is happening here. Now, this friend over here, it's the type 2 alveolar cell. This guy produced something called surfactant. I'm going to say again, surfactant. This substance, let's say, helps that this guy doesn't collapse. The lack of surfactant, it's going to make it impossible for this alveolus to stay open because it's going to stick to the walls. And no oxygen exchange is going to happen for one, and nothing is going to come out because this is collapse, right? Then, as we mentioned before, there are capillaries. We see one here, we see one here, we see one here, and this is where the gas exchange is going to happen by diffusion, okay? So there is going to be O2 coming into the capillaries, and there's going to be CO2 coming out of the capillaries to the alveolus. That gas is going to come out and kind of reverse track the whole trail that we have spoken about, which is part of the gas exchange. The reason this happens by diffusion is because this layer here is super thin that happens very easily. Right? Then we have the alveolar macrophage, which is that immune cell that is going to catch stuff that has kind of skipped all the security that happened in all the other levels, and this is kind of like one of the lines that is going to say, hey, why are you still here? I'm going to kick you out by eating you. Monocytes, this is another immune system. But for a purpose, I want you guys to memorize what the alveolar cell type 2 does, what the alveolar cell type 1 does, and what the macrophage does. What this guy produces, it's important. The type 2 alveolar cell produces surfactant. Okay? All right. Moreover, we have an alveolus here, and if you guys see, it's just a bunch of other alveolus that in a group is going to call alveoli. The type 1 cells are the ones that are lining the sac. Is where the gas exchange happens by simple diffusion, because the layers or the walls are so thin that the exchange happens between the capillaries and the alveolar space. Okay? Carbon dioxide moves from the pulmonary capillaries into the alveoli. Oxygen goes from the alveoli to the capillaries because we want oxygen-rich blood coming out of those lungs so we can get oxygenated, right? The type 2 cells produce surfactant that prevents the collapse of those alveoli. Babies that are born super premature lack, at that moment when they're super premature, that surfactant capability. So they need to be supported. Sometimes when it's possible, we can give surfactant to these kids. They also secrete antimicrobial proteins because we don't want anything that doesn't belong there to go into our system, right? And then the macrophages remove dust, allergens, pathogens, and other debris because we don't want that going in, right? All right, structures and organs of the respiratory system. So we spoke about, this is the respiratory area, okay? The respiratory zone, because it contains alveoli. So we got respiratory bronchioles that go into respiratory ducts, go into respiratory sacs. Those sacs contain a bunch of alveoli. In a single alveoli, it's an alveolus, and this is when the oxygen exchange happens, right? All right. So all these important organs, plus heart, plus liver, plus some of the stomach, plus some of the spleen, are protected by a rib cage. 12 pair of ribs, costal cartilage, the guy in the middle known as the sternum, thoracic vertebra, which are in the back from T1 from T12, diaphragm, which is the guy who's gonna divide where lungs and heart are to where the digestive system is, and also has a very important function. The diaphragm is going to expand, helping us with the expansion of the lungs. Let me rephrase that. The diaphragm is going to be that membrane that is going to help our lungs to expand down, and when the diaphragm contracts up, it also aids to those lungs to contract, helping with the respiration process, okay? As it is stated below. We have internal intercostal muscles and we have external intercostal muscles, okay? Nice. So now this is when we get a little bit nitty-gritty about what's in the air, okay? So air present in the air is not pure oxygen, because otherwise we'll explode. There's such a thing as oxygen poisoning. And also, I don't know if you guys knew this, oxygen is highly flammable. Way back in the year of dinosaurs, there was more oxygen present in the air, which is no longer the case in our days. So the air exerts pressure on our bodies. Think about like a column of atmosphere, and this is us here, right? There's pressure underneath us. The atmospheric pressure is the lowest at sea level and increases with elevation. Also, oxygen decreases, the concentration of oxygen decreases with elevation. As an example, I am from the mountains. When I was born, I had the adaptation to take more oxygen at higher elevations. My hometown, it's close to 10,000 feet high, so the oxygen availability is lesser there. The way you compensate that is increasing your production of red cells, because those are the ones that carry oxygen. When you leave those areas, you don't need as many oxygen cells. I mean, not many of those red cells, so you produce less. So when you go there, you don't have that adaptation anymore, and you become woozy and dizzy because you are working extra hard to get that oxygen. Okay? So, concentration of oxygen, and this is very important, I'm going to stress that, it's 21%. Nitrogen, 78.5%. Carbon dioxide, it's 0.04%. Water vapor, 0.45%, which makes 100%. And this is the pressure that is going on top of us all the time, which of course increases with elevation. Okay, with elevation, oxygen decreases. With elevation, pressure increases. Okay, so let's repeat that again. If we are going steep to a hill, oxygen concentration is going to be less here, but then pressure is going to be higher. But if we are here by the beach with a nice pina colada, the oxygen is going to be more concentrated here, but the pressure is going to be lower. Okay? Respiration. So, all this process that we talked about is the piece of external respiration. Air is going in to the alveoli, the gas exchange happens, and then we're going to talk about the internal respiration, okay? Something pretty important is that in the respiratory cycle, our friend the cardiovascular system is very connected. One can happen without the other because we need a heart and vessels to carry that blood and be pumped, but also we need the respiratory cycle and the respiratory process to where the gas exchange happens, and then that new blood that is enriched with oxygen can go somewhere and enrich the cells throughout our body. Okay? All right. Pulmonary ventilation. Air goes in, air goes out, right? So inspiration, air comes in, expiration, air goes out. Very straightforward. And I hope my little example with the inspiration and the expiration kind of helps. All right. So now we're going to talk about the process of inspiration. All right. Air is going in. We're going to suck in air. And this happens either voluntary or involuntary. Think about it. We don't think about breathing all the time. Okay? So the diaphragm is going to contract and move downward, just making kind of like a suction cup kind of thing, right? So we're going to go down. And then the external intercostals are going to contract and move the ribs upward, kind of like puffing our chests, right? So they're going to go outward and upwards. But then this also means that the pressure in our lungs becomes less. There's pressure contained in these lungs, and we're going to go more into detail that. What you need to know, if there's less pressure in, but positive pressure out, what's going to happen is it goes to the pathway of less resistance. Let me say that again. Pathway of less resistance. So what's going to happen? The pressure that is positive and higher outside is going to find a pathway of less resistance, so the air is going to go in, right? All this pressure, the positive pressure, plus the action of ribs and diaphragm going in these directions are going to expand our lungs that are going to be filled with air. This is the mechanical portion where air goes in and part of the oxygen exchange happen. Inspiration or inhalation. So now that the air is in and the gas exchange happened, now we need to take it out, right? So we need to exhale, expirate, take the air out, breathing out. So what's going to happen is the diaphragm is going to relax, going back to the initial state, and then the external intercostals are going to relax, going back to the initial position, right? Going downwards and inwards. And then the pressure is going to become greater than the atmospheric pressure. So, as the thing I was saying before, it's going to go from the pathway of less resistance. If the pressure is higher here, it has to find a pathway of less resistance, so it's going to go out, right? So the air is going to go out. This is a passive process. So the air that's in our lungs is going to go out. And that is the process of expiration. All right, components of the exhale air. As we were talking about, the air in our atmosphere right now is 21%, but the air that is coming out of our bodies, because it has been used, 16%. Funny enough, we tend to think like, oh well, it's going to use a lot of the oxygen. No, 16% of the air that we exhale is oxygen. Okay, same amount of nitrogen, but of course it's going to be richer in carbon dioxide because that was the whole purpose of the gas exchange, right? But also, as we were talking about, the air that is in and everything that is inside is warm and moist, so it's going to be higher in water vapor, right? Funny enough, if water is coming out of here, that also means that there's water being lost. So this is one of the ways that we also lose water. Not the main one, but this is where also water gets lost. All right, non-respiratory air movements. Coughing, something is obstructed and needs to go out. Sneezing, something is stimulated and needs to go out. Crying, producing the sound of crying also makes that our air goes out. And their movements, I mean, we need to, this is not a function of respiration. Anything has a purpose other than respirate. If you think about sneezing and crying, something obstructive or something needs to go out of some sort. Crying, we need to call attention, right? Laughing, empathy, something is funny. Yawning, we're tired. Hiccuping, just a reflex. And they're the result of reflexive actions, right? All right, external gas exchange. This is the external respiration. So it's a process by simple diffusion where O2 from air here goes into the capillaries. And the process of CO2 by simple diffusion goes from the capillaries to the alveoli, right? And here we see a red cell. This red cell is, well, thank you very much. Here's my oxygen. Well, thank you very much. Let me rephrase that. Let me just use a different color here. All right, so we have our red cell or erythrocyte, and she is carrying a bunch of carbon dioxide because it's carrying carbon dioxide from other cells. And it's saying, well, thank you very much. You guys can get off. Now the passengers with a bunch of oxygen need to go into this red cell so we can take it to the rest of the cells. Carbon dioxide gets off to the air. Oxygen goes in. Okay? Transportation of the respiratory gases in the blood. The friends that are going to be in charge of transporting all the oxygen are our friends, the red cells. So the oxygen has entered the blood capillaries from the lungs when the gas exchange happens, and these guys will travel throughout our bodies to carry that oxygen. So these guys are kind of going to be like the post people. They're going to be carrying the oxygen, and it's carried thanks to a molecule called hemoglobin. Okay? Hemoglobin has 4 spaces to carry oxygen. Okay? So factors that are going to affect the saturation of that hemoglobin to oxygen. So the hemoglobin can change the structure and shape. This is when we go to the molecular stuff. So we're talking literally shape of the hemoglobin. So it's more, has a greater affinity to oxygen. As I said before, hemoglobin has 4 seats for oxygen. But there are factors that can affect the capability of the hemoglobin to bind to the oxygen. So we talk about temperature, and that's why it's so important that that air gets warmed up. Oxygen levels. We are speaking that one of the factors is if there's not enough concentration of oxygen because we are in a higher altitude, that's going to be affected. Carbon dioxide levels. If oxygen it's fine or has an affinity to hemoglobin, carbon dioxide is a bully that says, no, I'm going to get in. And if there's more levels of carbon dioxide, it's more likely these guys are gonna get on those hits. Okay? Blood pH. As I said before, a lot of things are gonna affect the pH, and respiration is part of it. But we need to have a balanced level of pH so these processes happen. Okay? So all what we have spoken about is the external respiration process. Now we're going to go to the other side, the rest of our bodies. Cells are alive and they need oxygen and they also breathe and they also do processes and they also metabolize everything. So they also have respiration. So they're going to need oxygen and they're going to expel CO2, right? So there is a sort of gas exchange that's going to happen at this cellular level because there are no lungs involved here, but these guys still breathe. All of them. All the cells. I repeat, all the cells breathe and expel oxygen, right? So where do they get this blood? Rich oxygen. From the process of oxygen-rich blood that is coming from our lungs. And then they breathe all in, say thank you very much. Here is my carbon dioxide rich blood. And then this gets taken to where? The lungs. And the process repeats. This is what the internal respiration happens. Things that affect the metabolism of these guys is temperature, stress, pH sometimes. Also, if we are exercising, our muscle cells are going to be working more, so they're going to need more oxygen. So a lot of processes, or just normal working, like all the normal processes that they make, they're going to need oxygen and produce CO2. So this process is called internal respiration. Okay, carbon dioxide transporting the body. So there are three ways that the CO2 or carbon dioxide is going to be transported through our body. Okay? So most of the CO2 or bicarbonate, it's transported as a component of bicarbonate ions. So there are molecules in our body, or I should say in our plasma, of CO2. Plasma is the other component of our blood. They are red cells, and there's this big, nice fluid, let's call it, called plasma, where the rest of their blood components are. Okay? This is where the bicarbonate ions live. That's the main way. 95%, I repeat that, 95% gets transported as bicarbonate ions in our plasma. 5% of the CO2 attaches to plasma proteins and hemoglobin in form of carbaminohemoglobin. Okay? This is 5%. There's another 5%, and I know we're going like a little bit of 100, but this is like the other portion, one of the three ways, is as a dissolved gas, as CO2 itself, as a gas. But the main ones I need you guys to remember is the 95% that gets transported as carbonate ions in our plasma, then to a lesser degree with carbaminohemoglobin, or as a dissolved gas. Alright guys, so full circle. Air goes in, gas exchange happens, oxygen-rich blood goes to the left atrium, to the left ventricle, from the aorta to everything in our body. So we're going to the cellular level, where the systemic capillaries get in touch with the cells, and these cells are having the internal respiration process, right? So they expel CO2, go to the left, to the right atrium, I repeat, right atrium, to the right ventricle, to the pulmonary arteries, to the alveoli. And the gas exchange happen. So from here is blood rich in CO2 because they have been carried from the internal respiration. Gas exchange happen. Oxygen rich blood is coming. And the process repeats. Circle of life. All right, so as we know, we don't think about breathing. And when we think, we kind of forget. And then this is all taken over by, and that's my parrot. So the brain is the one in charge of that. So we have a piece in the base of our brains called the brainstem, and that controls the breathing. Any injury to this area, and we're basically done for. Because we stop breathing, we die. So the medulla oblongata is the one that controls rate, rhythm, depth of breaths, and the ability to breathe without assistance, autopilot. Okay? The dorsal respiratory group of the medulla oblongata drives and generates respiration. Okay? Dorsal part. The ventral part is the one that modifies the rhythm of breathing. This little friend here, let me just erase my bunch of scribbles. This little guy is called the pons, and basically a pons is a bridge between brainstem and brain. And this one interacts with the medulla oblongata with the small respiratory. Okay, here we see again our brain, but the main executive of the breathing is this guy. So, things that influence the breathing: how much our lungs are stretching, if there are any irritants, if we are working out. And this guy is a chemoreceptor. Chemoreceptors are related to pH level, other factors as well. So, if our pH goes high, meaning alkaline, we might need to stop breathing so fast. So if our pH goes down, meaning acidic, maybe we need to breathe a little bit more because we want to find that balance so the gas exchange happens and other processes happen. Okay? So physical activity, stretching of the lungs. Okay guys, so the pulmonary functioning can be measured and can be an indicator of great things and important things to assess health status. So as healthcare workers, I promise you guys, you're going to see this bad boy approve at some point. Doesn't matter if you're a nurse, it doesn't matter if you are a radiologist, doesn't matter what kind of healthcare worker you are, you will see this guy. This is an spirometer. So we have lung volumes and capabilities. This one is maybe the one that I will dedicate a specific section by the end of this week because it's very, very important. Tidal volume expresses VT. It's the volume of air moved in and moved out during one normal inhale and resting breath. Okay? Next one. Inspiratory reserve volume. It's the amount of air that you can breathe beyond normal exhalation. It's the one that you're just sucking until you can't no more. Okay? And it stands with IRV. expiratory reserve volume is the air that you can breathe out, force out beyond normal exhalation. So you're like taking all that air out, okay? IRV, ERV. Then residual volume is the amount of air that remains in the lungs after expiratory reserve is exhaled. So we're saying that the residual volume is the amount of air that is left even when we try our hardest to take that air out, okay? That's air that is there to keep the alveoli open, okay? And we're gonna go over this because this is one of the hardest that we kind of struggle to have the most comprehended. All right, then we have the functional residual capacity. It's the residual volume plus the expiratory reserve. So it measures the amount of air present in the lungs at the end of a passive exhalation. Okay? Vital capacity is the inspiratory reserve level, so all the air that we suck in plus the air that we left out plus the tidal volume. Okay? And this is the purpose of this measure is to delete that. There you go. It relates to the greatest amount of air that can be expelled from the lungs after taking the largest inhalation possible. So think about it. You're like taking a bunch of air in, the greatest, and then you blow it out. That's the tidal volume. Okay? It's like the biggest inhalation in the longest. Basically, what you want to measure is how much you were able to take in and how much you were able to get out. Okay? The inspiration capacity is the tidal volume plus inspiratory reserve. So it's the maximum, it's the amount of air that can be inhaled after the end of a normal exhalation. So nothing is forced. The total lung capacity is the vital capacity. So all the air that you were able to take in plus whatever is left when you let it out. And it relates to the maximum air that can be held in the lungs. How much you can hold in those bad boys, okay? Again, guys, this is a little bit more complex and we're gonna go into details. And I am going definitely to dedicate this weekend's presentation on this guy because this one can be complicated. All right. These are volumes. We're going to go into detail about these bad boys because this one is not something I'm going to go into one simple slide, okay? All right, the anatomical dead space. So basically, it's the amount of air that goes in but never participates in the gas exchange here. It's just air that is there, just hanging out, doing nothing. It's built into the anatomy of the system, but doesn't do anything. That air is just hanging in there, and that's normal, okay? All right. So in adults, I repeat that, adults, it's 15 to 20 breaths per minute, okay? In some cases, some of normal breathing can be present. And there are different kinds. There's like the Kussmaul breathing and some other kind of breathings, and they have some patterns. The ones that I need you to memorize, it's... So before we start this, let's delineate some things. Pnea, P-N-E-A. It's the term that we use for breathing, okay? So if we know hyper is a lot, means that we are breathing too much. So increase respiratory rate. This is the dysfunction or something is wrong. So there's difficulty breathing. All right. When you see A, it's the absence of something, apnea. So that means that we're not breathing, okay? We're either breathing too much, we are not breathing correctly, or we are not breathing at all, okay? So now we're going to talk about some of the things that happens out of the norm when we breathe. There's such a thing as carbon monoxide poisoning. And this guy is holding a canary. And I'm pretty sure you guys have heard of the canary in the coal mine. The reason why is canaries are very sensitive to gas changes in the air way before we notice. So what happens is, as we were talking, the CO2 likes to bind to the hemoglobin faster and stronger than the oxygen. And this is the guy that has the seeds for the oxygen. But if the CO2 goes faster and says, girl, get out of here, and the CO2 attaches to the hemoglobin, there's no room for the oxygen exchange to happen, right? So that means that there's no gas exchange, which means that the internal respiration doesn't happen. And happens is like we need oxygen to function. So there's only so long that we can take it, and then we get a little headache, nauseous, dizzy, shortness of breath, and then we die. This is what happens first in little animals, like our friend the canary. And that's why when people were in coal mines, this little guy, if he died, you know there's something going on, and they will go out. And that's why the saying emerged as a warning sign, the canary in the coal mine. Emphysema. So this is one of the part of the COPD disease. Depending on where you guys go, especially if you go with adults, especially with the older population, you'll see that people with COPD, you will have either emphysema or chronic bronchitis. So people with emphysema, the capacity of their alveoli ducts is just diminished. They don't expand as much. It's just like the capacity of them to perform the gas exchange and the elasticity of their lungs is just completely diminished. So a lot of these people acquire this condition because of smoking. So if your alveoli and overall lungs are not expanding and not being responding as a healthy lung would, they will have problems having a gas exchange. So usually you will see these people with increased CO2 levels. Okay? Hence, they do not tolerate physical activity as much. But also, they're going to exert more, and you will see these people with a lot of accessory muscles being worked more, if you think about it, because you have to breathe harder. And then what happens is like they get this barrel chest shape. Finally, people with chronic bronchitis, the bronchi are constantly irritated, inflamed, and produce exhale of mucus. So these people are going to have problem breathing. Why? Because as we were talking, there is the gas exchange. So I'm going to put this portion as the alveoli. This as the air, and this is the capillary space. If we have a bunch of inflammation in this area, and there's mucus in this area, the likelihood of the gas exchange happening is going to be decreased. So what happens is that these people are not going to breathe enough. They're going to be bluish because there's not enough oxygen happening, and of course they're going to have increased CO2 levels. Okay? And trying to obtain oxygen levels is going to be harder, so they're going to have decreased physical activity tolerance. And this, my friends, concludes the presentation for respiratory system. Bye.